I'm always intrigued by MRIs and where
Yeah.
the lesions are.
Mhm.
And I know, for example, I have a lot of lesions in my
Cerebellum.
cerebellum, sorry,
Yes.
and brainstem and somewhere
Mhm.
else there, but not so, and spine as well.
Yeah.
But I know that my EDSS is not so high.
Yes.
Is there a fallacy in the EDSS, or is there a need? What do these lesions mean? Is there analysis
Yes.
going into that type of stuff in general?
So the MRI provides you with a pictorial evidence of what's
Yeah.
happening. Its sensitivity, it can miss 40% of lesions. So
Oh, really? I didn't know that.
yes, it can do because but the higher the imaging sequences go in terms of their sensitivity, the better the pickup becomes.
Right.
And notoriously, it's poor for what's called the posterior fossa, which is at the back, so the brainstem and the cerebellum, which goes for every imaging modality available. Now, the counting lesions is good at the initial stage and highly predictive of disease progression in the first 5 years, but as the disease progresses or goes on, its predictive value starts to drop. So that's
How
why.
long period of time is that? So I know
Well, they say that in the first 5 years, but then if you go into 10, 15 years, the predictive capacity is a bit modest, is the term to use for that. I don't think you will get, I think MRI has its uses, which is that it allows the clinician to look at it and say, this looks typical of MS by the distribution of the lesions. It may also, depending on what type of lesion, where they are, might tell you how more severe the person's likely to progress. But if at a biological level you have a better repair capacity, for instance, that's not going to tell you, because you may be fine disability-wise. It has nothing to do with your EDSS score. It's just you have a better capacity or better reserve than the person who has less lesion load but seems to have progressed more. So the lesion number is not providing you any biological information. Whereas at the outset, if you had lower neurofilaments, you were more likely to stay in the CIS group as opposed to higher neurofilaments where you were more likely to be diagnosed with MS. So
there's a lot going on.
Yeah.
And I know it seems to be very much dependent on the individual and looking at
yes.
the overall picture.
Yeah.
And I know that with treatment in general, what are your views on failing something? For example, somebody going through 4 or 5 or 3 or 4 therapies quite in a very short period of time due to,
Yes.
say, and then something that touched a chord on was their liver function increasing.
Yes.
And maybe be transient. Mine fluctuates all over the place and then goes transient.
Yeah.
But I've been kicked off lots of drugs. Where is the balance, do you think? And does it have an
Yeah.
effect being on too many therapies in a short
Yes,
period?
so there is, in fact, increasing data coming in saying compliance to therapy and switching too many therapies is not great. And they were more predictive of progression if you switched lots. Now, it depends on, I suppose it's because people are having relapses in between the switching, which is what's contributing to it. But as a clinician, in terms of escalation treatments, it is a low-risk approach. So as you go up the tier, you increase the risk load. Whereas if you go for what's called induction treatment, where you give a full course of the treatment right at the outset, you're front-loading the risk. So these are differences in approach. I don't think there's a right or wrong answer. I think as long as a person's on effective treatment, then they should be on effective treatment.
I think for you, the statement you just said there isn't a right or wrong, and I think that's the perfect approach. I think the debate yesterday about hitting hard and escalating, I don't know why, because they have to present it, was a little bit, this is one way, and I think it has to be. For me personally, I think that balance is always an individual case.
I think personal preference plays a huge part in all of this, and but I think everyone's agreed that somebody needs to be on a drug.
Yes.
That's something which is a change from before. But now is everyone's of the agreement that your patients need to be on some form of treatment rather than nothing.
I know I'm talking a lot, but this is just so fascinating in general, and I know one area touching on escalation of drugs, and also about HSCT.
Yes.
And what is your? And I know a lot of people on, say, Shift MS forum and in general talk about it a lot.
Yeah.
What is your view in it in general? I don't like that question, but and also, for example, if you're failing, when to use it? Say, for example, you're failing something like Lemtrada.
Yes.
Is it preferable to use another round of Lemtrada or go to the stem cell? And
So just to point out, Lemtrada is part of, in some cases, part of the induction protocol for stem cell mobilization.
Okay.
So, but I have to say I'm still not decided one way or another. It is not a panacea. That's important to understand because disease activity does start coming through after 10 years. So it's not a cure. What this is a severe form of immunosuppression. Now, I do see in a particular subgroup, i.e. young people with highly active disease, I would like to use it, but it's not available to me as first line. And what I call aggressive disease to get it under control because you know that the repair capacity is huge in younger people as opposed to older people. In older people, I'll be a bit more reticent because of the safety profile not to use HSCT in them because the mortality rate increases substantially as you age from making your bone marrow negligible. There's nothing happening there and you're at higher risk of infections, which is the primary problem with this type of treatment.
I totally agree. I know that a lot of people see it as the cure, and I have to calm them down, including my family. They'll see something on the BBC or somewhere else, wherever. And that's an area where I think, I don't know what communication or getting a balanced view is important, and
I think education is important. Get a balanced opinion and then make the decision. And you will find often once a treatment is in the market for some time, the opinions start repeating themselves and then some consistency in approach becomes more universal. So it is just get yourself to know about. Don't go overboard because personal opinions are not evidence-based opinions. You have to look at what the data is showing and say, oh, it's showing that. So as far as HSCT is concerned, they talk about mortality risk. That is improving these days. And
is it around, I know it was 5% before.
Yeah, it's so generally now it'll be 3 to 5%, but in fact with variations in induction protocol and experience of hematologists who do this procedure for MS physicians, like the Sheffield group yesterday talked about 0.2% mortality risk, which is an amazing mortality risk to quote. So I think it's improving. So I'm, as a clinician, more happier to use it in those very highly active, just to get good disease control early on.
If the stats improve like that, then it's...
I don't think it's a cure.
No,
I use it as a heavy immunosuppressant. That's what I will be using it. At the moment, the Pan-London HSCT group have decided that you would have to fail 2 disease-modifying treatments, and you need to have evidence of disease activity.
In the MRI at the time.
Yes, at the time, and that is a bit of a problem. And the same rule applies for people with progressive MS as well. And we know that lesion load is much smaller in that cohort, so it's very selective. And I don't think that there is a huge data there which shows a positive outcome on it being used very late, if you get my meaning, because it's just an immunosuppressive treatment. The approach for that group needs to be more neuroprotective therapies. If there is any remyelination treatments, it needs to come in. You know, these kind of approaches are what should be considered in the later groups. But if you have inflammatory activity on the scan, then why not? You know, that's an option. That's how that guideline is set out.
Yeah, and I might be completely wrong, but is it that if it's highly aggressive, time is really important because it could get to a point where it's not going to have likely chance to helping, which I can understand how frustrating it would be for the patient, the doctor, and if knowing that there was potentially something that
of course.
Available, but it has to be used in the right way and not for everybody.
I mean, there's a saying in the stroke arena, time is brain. And I think the same could be applied to MS, really. If you wait too long, you are losing brain physical brain tissue which is contributing to how you're working and how you're functioning. And that's not something we can get back.
No.
That piece of brain is not going to regrow.
Yeah.
And early hitting it hard and fast approach makes sense in that respect. So you tailor it to the person, and you can't go wrong if you tailor it to the person.
Yeah, I totally agree. I know, promise you final question is just what would you like to see next year? What do you think was missing almost here? Or,
It goes without saying, I want to see proper phase 3 studies for progressive patients. I don't think MS stat is just starting to recruit, but I would like to see larger cohort studies. I would like to see some joint effort to see how this impasse we have with regulatory authorities as far as licensing these drugs for this disease group can be overcome. So I think the focus of next year's ECTRIMS, if they're willing to do it, should be at that. Also, it was touched upon on this ECTRIMS, which is the inequity of provision of DMTs. Some of them, some countries had very few people on the highly active treatments, which is unheard of in the UK. We're fortunate in that respect that we can quickly escalate and know that if we stick to our guidance, we can get reimbursed for the drug. But whereas in other countries, like Poland, which was given as an example, hardly anybody was on highly active treatment. So that's unfair.
yeah, I totally agree.
So I think those are two areas I would like covered in next ECTRIMS, because everyone wants answers to those questions.